A very good afternoon to all of you, and it is a great pleasure to be here today. Thank you very much for the organizers to have given some time to us in context of the fact that we are going to show you today a little bit of an overview of first ever India discovered novel antibiotics. So as you are aware that our country has never been able to discover entirely new antibiotics in last 75 years, and as a result, while we continue to remain as a country known for make in India, but now slowly I think we are moving towards innovate in India. And I think it looks like that we are taking some many steps towards the direction. So what I am going to discuss with you today are the two novel antibiotics, Levonadifloxacin and Alalevonadifloxacin. They have been brand named as EMROK and EMROK O. And these antibiotics have been developed keeping in mind that we should be able to cater a wide range of infections in the wide range of clinical settings. So on one hand, they have been designed to treat acute infections in ICU like respiratory infections or bloodstream infections or pneumonias. But on the other hand, they are also very well designed to treat chronic infections like diabetic-foot infection and bone and joint infection. So a little bit of an overview of these antibiotics. We have availability of both IV and oral, as you can see in the presentation of the first slide. I think all of us are aware about the fact that majority of diabetic foot infections do need antibiotic intervention, except for the uninfected, mild, moderate and severe level of infections do require effective antibiotics. In the case of milder infections, a safe oral antibiotic for 1 to 2 weeks may suffice the need. However, for moderate and severe infections that may involve deep-seated wounds or even osteomyelitis, they may require IV antibiotics as well as potentially oral antibiotics as a step down. So there is a need for an IV as well as an oral antibiotic to effectively manage these infections, particularly when they are moderate or they are severe. Again, a very common slide to know about. However, still there is a lot of debate and there is a lot of contradiction as to which is the number one pathogen in diabetic foot infection. So while there are contradicting reports, one has to ensure the fact that a drug that has to be used to treat these infections needs to be a broad spectrum drug, because one thing is for sure and agreed unanimously that diabetic foot infections are polymicrobial. They involve more than one pathogens. Some of the pathogens are kind of an usual suspect, Staphylococcus aureus, then for example anaerobes, to some extent streptococci and Coagulase negative staph. They are kind of a usual suspects in diabetic foot infection, and therefore you need drugs which are broad spectrum and can tackle all these pathogens, including the resistant ones involved in each of these genera. While selecting an antibiotic, it is very important to keep two important factors in mind. One is the patient-related factors, and then of course there are some antibiotic-related factors. When it comes to patient-related factors, I think most important is to look at multimorbidities that could be there in the patient in terms of, obviously diabetes is one of the signature feature of diabetic foot infection, but hypertension, renal or hepatic dysfunction, immunosuppression, and many a times the patients have either the cancer or they are in the organ transplant. Apart from that, prior use of antibiotics, previous exposure to healthcare systems, and involvement of deep-seated infections like osteomyelitis, they all can impact the selection of an antibiotic. In terms of antibiotic, to address above factors, the drug needs to have a very broad pathogen spectrum coverage so that a single drug can suffice the need for the treatment of diabetic foot infection. Whether the drug is bactericidal or bacteriostatic is very important, because these are the infections where a rapidly cidal action drug is required. IV and oral option availability of both is an ideal situation as far as management of diabetic foot infection is concerned. Whether the drug has a good vascular concentrations and tissue concentrations is also very important, because that's where the drug will permeate and reach to the site of infection. And of course, most importantly, there has to be safety for extended use, because these are the patients who may require the treatment to be done for as much as even 6 to 8 weeks, and therefore you need to have an IV as well as oral option which can be given over these many 6 to 8 weeks duration. Apart from that, if there is a biofilm action available with an antibiotic, then it is a very interesting characteristics, because through which the diabetic foot infections are known to cause a lot of biofilms, the pathogens that are involved. And of course, you need to have an improved or unchanged activity under acidic condition, because the diabetic foot, just like skin infection, has an acidic environment. Moving on to some of the last line therapies that are used today as a salvage therapies for the treatment of diabetic foot infections, particularly those involving gram-positive pathogens. They are vancomycin or teicoplanin and linezolid. From the DFI point of view, we are of the view that there are significant limitations that are there in the context of the patients that we are seeing today, that is full of multimorbidities. I think for vancomycin and teicoplanin, a slow saddle action and the risk of nephrotoxicity is a major limitation in the managing diabetic foot infections, because majority of such patients have a renal dysfunction. Apart from that, what limits their use is the narrow spectrum, because these pathogens, as we discussed, these infections are polymicrobial, and absence of an oral option. So what it means that through these drugs, you cannot use a patient in a community setting or in an outpatient setting, nor you can step down to an effective oral antibiotic. On the right side, we have linezolid. Though it has an oral option available, however, it cannot be given for more than 10 days. That limits its use in the diabetic foot infection, and plus the drug is bacteriostatic. So these are some of the limitations of these antibiotics. Apart from that, if you look at some of the oral antibiotics, they are age-old antibiotics, more than 40 years old, and all of them have one or the other limitation in terms of managing contemporary patients, today's patients, and today's pathogens. For example, clindamycin cannot tackle MRSA in a comprehensive manner. Cotrimoxazole has a poor concentrations in the tissues and a lack of bactericidal activity. Minocycline, though, is being used for the management of these infections to a small extent, however, does not have a long-term safety, and its efficacy has been established in diabetic foot infection. And linezolid, we discussed, causes thrombocytopenia or anemia with more than 2 weeks of therapy. So these are some of the glaring gaps in the current armamentarium that we have as far as antibiotics are concerned. And as a result of that, we thought around 20 years back that we would like to have a drug which can bridge all these gaps as far as possible. And therefore, our objective was to bring about a very patient-friendly antibiotic. Patient-friendly antibiotic means an antibiotic which can be given to a patient without ifs and buts. And that is what the whole objective of this project was. And over 20 years of our research, we were able to get these drugs available to the clinicians in India. So the idea was basically try to cover as much as resistance mechanisms and as many as pathogens. So this drug ultimately became a broad spectrum drug with a complete coverage of all the gram positives regardless of resistance mechanism. IV and oral option was a must for the project goal, and therefore we developed both IV and oral option with 90% oral bioavailability in such a manner that I will show you that both IV and the oral pharmacokinetics are almost superimposable, which is a very rare situation to be in. This drug has almost now set a new benchmark of safety, because we have treated till now more than 45,000 patients in the real world. We have a 3,000 patient post-marketing data and 1,000 patient clinical data, and all that has given a lot of assurance that as far as safety is concerned, we have really set up a new benchmark as compared to the existing antibiotics. I think what comes very handy, and we are finding a good traction from the doctors, is that this drug is very easy to use. You don't need any dose adjustments for hepatic or renally impaired patients, which could be a situation in many of the diabetic foot infection patients. The drug has a minimal drug-drug interaction potential because it is not metabolized by cytochrome P450, and therefore this drug can be given with many other co-medication drugs, and of course bactericidal. So these are the features that we tried to build in and design the antibiotics, and finally we are happy to inform you that most of these objectives have been met with EMROK and EMROK O. So just briefly touching upon because they are new chemical entities, the structure plays the key role. This structure is 90% different than the structures of other fluoroquinolones from the medicinal chemistry point of view, because the core is a completely different core. This core is called as a benzoquinolysine core, and the side chain has been modified to replace with hydroxy in place of amine, which is a common feature in most of the other fluoroquinolones. And what we have on the right side is a unique L-arginine salt, which allows injection site safety to the molecule, so that you can administer this drug IV for over 2 to 3 weeks without any tolerability related issues. Likewise, we went on to invest almost 3 years in developing a oral form of this drug, and that was possible only through the prodrug approach. We screened more than 70 prodrugs over 3 years and finally identified that another amino acid came into the rescue for us. This is an L-alanine salt of Levonadifloxacin, and therefore it is called as Alalevonadifloxacin, which is brand name is EMROK O, and this provided us a beautiful prodrug that delivers the Levonadifloxacin in an active form in a very seamless fashion, as I will show you in the next slide. Look at this slide. This is a clinical data from US phase 1 study where we showed that when IV and oral both are administered to healthy subjects, there is almost a superimposable pharmacokinetics both for IV as well as oral, including the Cmax matches. This is rare in the case of oral antibiotics, that the Cmax also comes as close as to the IV Cmax. So that's what happened with this drug. And our subsequent research showed that this is because of the fact that this drug gets very effectively recognized by amino acid transporters from the intestine. So as soon as the drug goes into the intestine, there are amino acid transporters. They pick up the oral antibiotic, get into the systemic circulation, and the active drug is released into the blood. So through that, the PK is almost superimposable, which means that it allows you a very nice IV to oral switch, or you can even begin the treatment with an oral drug without any risk of losing the efficacy. So bactericidal effect of these antibiotics are very well established now, and that was one of the project goal. You can see here that we have used antibiotics from 7 different antibacterial classes. You can see here beta-lactams, lipoglycopeptides, oxazolidinones, glycopeptides, clindamycin is there, tetracyclines. Among all the class of antibiotics, it is only EMROK which brings about 99% kill in a matter of 8 hours when we start with 7.5 log CFU of MRSA. So very potent bactericidal action has been demonstrated for these antibiotics, which is very useful in severe infections where you require a rapid bactericidal action. Further profiling over years showed that this drug has a very nice broad spectrum of activity. There is a comprehensive coverage of gram positives, including all the resistant variants. It covers respiratory pathogens, Haemophilus. It covers even the ciprofloxacin susceptible gram negatives like Enterobacteriaceae and Pseudomonas. Anaerobes is one of the strong point of this antibiotic, and also several atypical respiratory pathogens. So a very wholesome, complete coverage that is available with this drug. And from the diabetic foot infection point of view, I think I will like to point out gram negative activity, anaerobic activity, and MRSA activity. Our previous speaker highlighted the biofilm, importance of biofilm action. The biofilm is given to this antibiotic as a very powerful action. This drug has a biofilm activity. As you can see, daptomycin, clindamycin doesn't have it. We also demonstrated that this drug has a ability to reduce pro-inflammatory cytokines like IL-6 and TNF-alpha, which is a beneficial for clinical benefit of the drug. The drug has an ability to reduce virulence of MRSA in vivo, both the hemolysin as well as cell-bound protein A. And through that, I think I will just take last 1 minute to show you that the drug has been very extensively studied in phase 3, and we have an actual data from the diabetic foot infection from our phase 3, where we showed eradication of range of pathogens in the phase 3 through both clinical cure as well as microbiological eradication. AST methods are available, and the drug has shown potentially a wonderful safety profile, and therefore we believe that it has a potential to really replace older drugs that we are using today for diabetic foot infection, such as those listed on this slide. And I really thank you very much for your attention.